The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We have the great good fortune this month of being able to talk to Dr. Jeremy Kendrick, a terrific child psychiatrist and one of the key participants in the call-up program here in Utah. Welcome back, Jeremy.
Hey, thanks, Paul. So glad to be here.
All right. And again, a shout out to the call-up program. We will, of course, post the number in our show notes. It's such a great resource. And as a practicing pediatrician, there are times that I think I have the advantage of having a relationship with the family, but that doesn't mean that I have the expertise. And being able to talk through problems with somebody who knows what they're talking about has just been a wonderful thing.
Well, I will say that some of my favorite conversations with my pediatric colleagues have been through this line, and even friends that I trained with, I'll hear from on the line occasionally years later. I'm just always impressed by the level of awareness and information that pediatricians do have. And again, I think we also in this call-up line will talk to mental health practitioners from across the state. It really is a peer consultation and an opportunity to just get a fresh set of eyes or ears rather on these really tough cases. And so we love it. I think they're fun conversations. They're always educational on both sides.
And so vital, because this is so central to what we both do. Have you developed any disclosures since we talked last week?
I have not. Nothing to disclose today.
Okay. All right. We'll run an ad for you.
Thank you.
This week, and again, this month, the psychiatry grab bag, some things that I've wanted to talk about, and it's all about me and my needs this month. But I want to talk about panic disorder, because usually we talk about panic disorder as being a subset of anxiety, that we talk about anxiety with or without panic. But I think for one thing, some families who are reluctant to talk a lot about anxiety are still overwhelmed by kids who have panic episodes. And panic episodes can be very frightening.
100%. I think that is what sets panic apart as far as a panic attack or panic episode from just your run-of-the-mill anxious kid. And that is that a lot of times kids that are anxious will almost have a little bit of awareness into the idea that they're anxious. They can have maybe a little bit of a stomach ache, or they can have some somatic representation of that anxiety, but it's pretty clear to everyone involved that that's what's going on. But you compare that to a kid who comes with an acute onset of some somatic complaint that for all intents and purposes could be an underlying red flag for a really dangerous medical episode. It all of a sudden gets everybody's attention really quickly, but it was also intensely stressful, because understanding how to sort that out as a parent at home, even as a pediatrician in your own office, I think it becomes a very complex situation that warrants a pretty sophisticated approach.
So how do you describe a panic episode?
I think panic for me is the idea of anxiety to the point that there's a false alarm with real body symptoms to an acuity that would mimic a medical emergency. And these are kids that present with chest pain. These are kids that present with shortness of breath to the extent that maybe they have an acute respiratory condition that you're concerned about. You can have neurologic presenting symptoms, dizziness, lightheadedness. I've seen kids with the most severe nausea and emesis to the point that I was sure they had some sphincter that was, it's just the dramatic way in which these symptoms can present, and can present acutely even in a patient who over the last weeks has not presented in that way. And so it really is that change and that lapse into that acute state that I think sets this apart from your normal run-of-the-mill presentation of anxiety.
It seems also that they describe it directly. It seems to me also that some of these kids are kids who are avoiding things that may exacerbate their panic. And as a result, either because they don't want to talk about the panic part or because they don't necessarily have the vocabulary to talk about it, these are kids who are just missing a lot of stuff. Kids who are not going to school, kids who don't want to leave the house for lots of reasons, kids who are in urgent care and in the emergency department a lot without necessarily definitive diagnosis. Am I off with that?
Not at all. I really see avoidance as kind of the core mechanism that facilitates panic. And that is because the brain of an anxious individual does not want to feel that way. And if there are particular stimuli, be it an environment or an event or anything like that provokes anxiety, the brain can get pretty savvy with how it can create a situation that helps the patient avoid that stimulus, and to the point that it will recruit its other organ systems to manifest somatic complaints and somatic symptoms that demand the attention of those
Mhm.
around you. And this is the real insidious part about panic disorder, is because it facilitates avoidance, which in and of itself is this reinforcer for more episodes of a similar nature. And so that is why looking at avoidance and addressing avoidance as a core mechanism of this is such an important part of treatment.
And it's quite clear that the patient themselves or the caregiver may say, no, they're really not making this up. And that's clear that they're not making up what's going on, but it's out of proportion. And when you look at the possible underlying causes, it doesn't connect.
100%. And I think a lot of times we approach panic disorder as a diagnosis of exclusion early on because we really want to rule out some of these more kind of acute medical causes of these symptoms. Yet when we kind of reach this diagnosis, then I think it becomes really important to recognize it then as a diagnosis of inclusion moving forward, and that it is not as simple as recognizing that anxiety was a pre-existing condition to the panic attack, because most panic attacks, actually it's the somatic symptoms that predate the recognition that there was anxiety. And like you said, most kids will talk about it not making sense to them. And I've had many patients where I've said, well, was there anything going on around this that you could attribute to? And they are oftentimes at a loss. Now, that's not uniformly true. A lot of
Mhm.
times panic will come on from a very identifiable stressor. But I think it is important to recognize that just because a patient cannot identify a stressor consciously or verbally does not necessarily rule out the possibility that panic is involved.
Does having had a panic attack in a particular situation increase the likelihood of another panic attack and of an anticipatory panic attack?
Yeah, absolutely. I mean, I think this gets to this whole idea of avoidance, right? If you've experienced these symptoms in an environment and it facilitated avoidance of that negative stimulus, from a behavioral standpoint, the brain's going to go right back to that same coping skill, in this case, a bit of a maladaptive coping skill. But it's very easy for the brain to get right back into that pattern. And that's why you see these kids with these really chronic presentations. And so I think identifying early on the environments, the situations, those types of things that are more likely to provoke this, and utilizing that information and how you design a treatment plan is really important.
How much exclusion do I need to do?
Well, I think that is partially based on history. If this is a kid that maybe has an underlying anxiety disorder and there are some of these symptoms there, I think that is a bit of a different workup than the kid presenting with absolutely no history of it, no family history. And I think that is where you trust the evidence base for certain types of symptoms, what you need to do for a due diligence standpoint. But I also do not think that it warrants or necessarily even helps to have the most comprehensive workup every single time, because that in and of itself, I think, contributes to this idea of avoidance and not addressing the core issue of panic, which is avoidance.
So this is clearly a diagnosis that's more common in people who have anxiety, correct?
100%. Yeah.
There's often a family history of anxiety. And so I find that one of the hardest discussions is that this is often triggering the parent's anxiety as well.
Yeah, and I think that is the dynamic that's really important to recognize, because, and we all know this, those of us who are parents, that you don't want to see your child in distress. But again, that child's very anxious brain recognizes that dynamic pretty quickly. And I have found that these anxieties can just absolutely feed off of each other. And so if you recognize that dynamic, and this is one of the challenges of working with kids and adolescents, is you're oftentimes dealing with the acute symptoms of the patient, but also in the context of what you're observing from the parents, and helping to provide some education to the parents on how working on that dynamic in and of itself can be a very important part of the treatment plan for their child as well.
Is there a best way to broach the topic?
Well, I like to normalize the idea. I mean, the fact of the matter is, if a parent has brought a child in, that's where I will say one of the things we know about this condition is that the likelihood of first degree relatives having these types of conditions is much higher. And I always like to just check in and see how everybody else is doing. Are these symptoms that anybody else in the families ever struggled with? Are these symptoms that you have struggled with? And I found that most parents even though they may not feel like they have the tool set to be fully aware of how to manage it themselves, they're aware of its presence. And I think the recognition and awareness of it is obviously that first most important step to being willing to become part of that treatment plan that involves a whole family dynamic.
All right. So given that, what helps? What do we know from an evidence base that is going to help somebody who's having panic episodes? Because they're very distressing. Whatever the underlying cause, they're very distressing.
Yeah. Well, and this is where this becomes such a difficult topic because it is an emergent situation, right? It tends to pop up. They're at your office because of this. They're
Yeah.
at an emergency department because
Yeah.
of this. And when people are in that acute distress, what they want immediate relief from those symptoms.
Mhm.
And so it's very easy to fall into the trap. And I won't call it a trap because I think there really is a good evidence base for rescue meds that can help quickly de-escalate a patient or help them get back into a state where they're more calm and it calms these symptoms down. That said, if your long-term treatment strategy is just relying on those acute interventions, I think you really do miss the mark of actually treating the condition itself. At that point, it's kind of like Tylenol for a fever without addressing the underlying infection. And so I really think that the important piece of management here is understanding how we treat the underlying anxiety, underlying symptoms that set the patient up to be able to experience those types of panic attacks. And that really falls into two categories. We have our biologic pharmacologic category, and then you have your therapeutic category. And those are both very important. And I think we have really good evidence to show that the combination of the two together is always going to outperform either on their own. And so I think a good treatment plan strategy involves both. So the easy part of this is the pharmacologic piece because that's a pretty straightforward approach that you can talk with your patients about, you can review. Taking a pill is pretty easy compared to some of the hard work that comes along on the therapy side. And when you talk about medicines, really your SSRIs are going to be your cornerstone of management. And this won't be the first time that folks have heard this, but we don't have any good head-to-head evidence showing superiority of one SSRI over another. And the approach that I have found most successful in primary care is find one or two SSRIs that you feel comfortable with, that you feel like you understand the side effect profile, and lean into those. And if you have a patient who's refractory and you want to try something else, that's fine. But most patients, it's not going to make a difference which medicine you start with. It's finding a good serotonergic medication that will be helpful, and picking amongst the more commonly used SSRIs in kids is you're going to do just fine with that approach. So whether that's sertraline or fluoxetine or escitalopram, the SNRIs do have some evidence, duloxetine, but I will say personally, it's not mine to start with. I found the N part of that, the norepinergic tone, I just felt like it's gotten in the way a little bit. So I would definitely start with your SSRIs as your go-to. The harder part really is the behavioral and therapeutic part of this. It's hard because it is hard work for these patients because you're basically asking them to challenge the very thoughts that feel so real to them, and oftentimes challenge these thoughts in the environments and conditions that are most likely to provoke them. And so cognitive behavioral therapy, which is really the cornerstone of most anxiety treatments and panic as well, really has to do with the idea of helping a patient take a step back and understand the process that goes into their thoughts leading into these situations, because those thoughts oftentimes lead to the behaviors. There's thoughts and feelings and emotions attached that lead to the behaviors. And the behavior in particular that we're worried about here is avoidance. And so a lot of times this really is similar to the types of treatments we see in things like obsessive compulsive disorder, which is this idea of helping the patient have some mild exposure to situations which might provoke this in a controlled fashion, and allowing them to be able to sit and understand that physiologic response does not have to follow. That by using some skills, be it deep breathing skills, and that's why the cornerstone of really good CBT is oftentimes starting with what are the skills we're going to use when we do start to feel those physiologic reactions to our emotional state. If a patient can enter into the potential environmental state that can provoke those feelings with an armament of skills that might help dull that response, avoidance isn't the thing that they immediately will jump to. And that is the whole process of CBT. It's replacing avoidance with more adaptive and appropriate responses in any given situation that literally retrain and rewire the brain to operate differently so that when that stimulus comes in the future, it's not automatically provoking these physiologic responses that are just yelling and calling out for avoidance.
What about the medications that are sometimes used as rescue medications? What's the role for something like hydroxyzine, for instance?
Great question. I love hydroxyzine. Hydroxyzine is an effective medicine in these scenarios. That said, I do think that it is not a long-term panic solution. It definitely is a med that's listed in the ACAP guidelines as far as agents that we will use, the American Academy of Child Health Psychiatry, that we'll use in these, but they're not without risk. Hydroxyzine can have some issues with QT prolongation. And I think if you have a patient with issues with QT, that is a med that you'd want to take caution with. But I find that hydroxyzine works the best for patients who can sense they have some foresight into the fact that they're maybe heading into a situation where they've had panic in the past, where there's some foresight. I found it much better as a preventative strategy during a known acute stressor, as opposed to, say, benzodiazepines, which I think are a much more effective abortive approach. Benzodiazepines have when you look at them in the context of like controlled anxiety trials, as far as long-term solutions, obviously they're riddled with all sorts of problems as far as tolerance and dependence and all these types of things that we run into. That said, for a patient who is in an acute state of distress where they are beyond the ability to engage with coping skills, and it really is a matter of just getting them safe, benzodiazepines can be highly effective in those situations, and they can be good short-term adjunctive rescue medications in addition to an SSRI. Having an SSRI on board is going to be probably the single most well-studied and well-proven strategy to prevent the likelihood of these episodes occurring. But in those patients who are in that acute state already, benzodiazepines can be highly effective. It just really is, I think, using them rarely, using them briefly with kind of clear stop criteria is going to be your safest approach.
I've seen gabapentin used sometimes in older adolescents and young adults. What's the story there?
Yeah, it is one that definitely has trickled down from our adult colleagues. It's been used off-label for anxiety for many years. I would say the data around pediatric anxiety and specifically panic, the data there is much more limited. I have absolutely utilized it as a kind of an in-between between hydroxyzine and benzodiazepines, more specifically to try to prevent situations. The issue with gabapentin is we're learning more and more that it is something that can be misused. We're seeing more and more cases where it has these unintended effects for a certain subset of our adolescents who are maybe at higher risk for diversion of prescriptions and misuse. So I would use it with caution in adolescents. And I think the more important thing, not to sound like a broken record here, but I think if it's avoided in routine scheduled use, specifically around panic. Now, for some kids with really chronic, stubborn, generalized anxiety that's just crippling kind of over a period of time, as opposed to these acute, discrete, episodic, I do think there's more of a role of coming up with a strategy there, but it's one that you just got to be very careful with, especially if there's any risk of substance use disorder in your adolescent patients.
So if we think of panic disorders being a little bit like asthma, that we're looking for what do we do in the event of an episode and what do we do to decrease the number of episodes? So the albuterol and then the preventive medications, what direction would you go?
So I think it really depends on the patient, the situation. I think every patient is going to need to be on one of these maintenance medications. I think the SSRI medication is the best way to go. I think choosing a rescue medication for those situations where you're trying to kind of get things under control. This is the first presentation. You've recognized it for what it is. You're getting the patient on a long-term maintenance strategy. But if you find yourself 2-3 months down the road and you're still dealing with the same frequency, that's where I'd be really cautious with overuse of the rescue medicines, because it can become a bit of a crutch that patients will lean on that as opposed to really the most important thing, which is avoiding reinforcement of avoidance. And these medications can absolutely be a form of avoidance.
Yeah, that plus the notion that learning through cognitive behavioral therapy that you can treat the episode with non-pharmacologic means is very powerful.
It's incredibly powerful. And this is something that I talk to my patients in general. I'll say, can you control your heart rate? Well, no, not necessarily. Well, we talk about the symptoms of anxiety. We talk about increased heart rate, but increased respiratory rate is another real one. These patients that become tachypnic and they're hyperventilating. Well, can you control your respiratory rate? Oh, yeah, you can. And when they begin to learn that it's a two-way arrow, that you can control your respiratory rate, and that sends signals back up to the brain saying, oh, okay, things are not as bad as my brain thinks they are. And there's very real evidence on the power of that. And then that in turn then affects the other organ systems, and your heart rate can start to come down. So it's picking those physiologic entry points that we do have control over, and breathing and relaxation, progressive muscle relaxation, become really important tools to be used. And I think most adolescents who have been through a lot of therapy and programming, I found the ones that roll their eyes at that are oftentimes the ones that never really have truly sat down and had somebody really go through a good deep breathing exercise or things with them, because it's potent, powerful stuff.
Because it does entail needing to buy in. You have to believe that you can take control and be interested in taking control. But it does seem like that a panic episode is an extremely out of control feeling, and this notion that you can take control should be empowering, I hope.
100%. And I think that is where focusing on respiratory rate and some of the progressive muscle relaxation skills becomes so important, because it literally is something you can sit down with the kid and do right together with them, and they can get some pretty real world results. And yeah, when they figure that out, it's almost like they got a little bit of a superpower there in order to have some more control over their physiology that they felt they didn't have before.
Terrific. Any other wisdom?
I really do think the key to treating panic disorder is using medications sparingly from a rescue standpoint, having them on a good maintenance medicine. But the most powerful thing in my book is the behavioral management of this, and getting kids to a point that they really do get some empowerment over that. And until that point, it's really hard to prevent these episodes from recurring, because the kids just don't feel like they do. As always tends to be the case, a healthy dose of combination of medications and therapy are going to be your best bet.
Perfect. Well, thank you very much. I'm sure there'll be questions. Please send your questions to questions@thecurb.com. We'll deal with those in a couple of weeks. Jeremy, thanks for spending some time with us this week.
So happy to be here. Thanks for having me.
All right. I bet you're pretty excited to find out what the last part of the grab bag is going to be next week, right?
I'm so excited. I can't wait.
Well, do some deep breathing. See if we can get you through that. All right. Thanks for being here.
Thanks, Paul.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way, and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.